The thyroid gland is located in the anterior neck, scanning between the C5 and T1 vertebra. It is divided into two lobes, which are connected by an isthmus. It lies behind the sternothyroid muscles, wrapping around the cricoid cartilage and superior tracheal rings. Blood supply to the thyroid gland is achieved by two main arteries, the superior and inferior thyroid arteries. These are paired arteries arising on both sides, left and right. The superior thyroid artery is the first branch of the external carotid artery. After arising, the artery descends toward the thyroid gland. As generalization, it supplies the superior and anterior portions of the gland. The inferior thyroid artery arises from the thyrocervical trunk, which in turn is a branch of the subclavian artery. The artery travels superomedially to reach the inferior pole of the thyroid. It tends to supply the posterior inferior aspect of the gland. Venous drainage is carried out by the superior, middle, and inferior thyroid veins. The superior and middle veins drain into the internal jugular veins, whereas the inferior drains into the brachiocephalic vein. There are two recurrent laryngeal nerves in intimate contact with the gland, one left and one right. They arise from their respective vagus nerves and descend into the chest. In the chest, they hook around the subclavian artery, the right recurrent laryngeal nerve, or the arch of aorta, the left recurrent laryngeal nerve. The nerves then ascend back up the neck, running between the trachea and esophagus. They pass underneath the thyroid gland to innervate the larynx. During surgery on the thyroid gland, care must be taken not to ligate or damage the recurrent laryngeal nerves. Parathyroid glands are two pairs, superior and inferior, located on the posterior surface of thyroid gland, outside its capsule. The superior pair is more constant in position, and it is usually located about 1 centimeter above the bifurcation of the inferior thyroid artery to the gland. The lower pair is more variable in its location. The gland is oval in shape. It's about 6 millimeter in length and 3 millimeter in width. It is yellow-gray in color, and it should be differentiated from the thyroid nodules and from the lymph nodes in the area, because excision of parathyroid glands will lead to permanent hypocalcemia. Its blood supply is from an end artery, so manipulation during surgery might affect the blood supply to the gland due to spasm of this artery, leading to hypocalcemia, which is temporary. Thyroid gland produces and releases thyroid hormones T3 and T4. Thyroid cells are arranged in follicles. Each cell is a specialized epithelial cell, which function by trapping of iodide from the blood, and then oxidation or iodinization of iodide into iodine by enzyme thyroid peroxidase, and then the iodine undergoes a series of organic reactions within the thyroid gland to produce tetraiodothyronine, which is thyroxine, and triiodothyronine, which is T3. T3 and T4 are stored in the thyroglobulin protein of thyroid gland and released into circulation under the effect of thyroid stimulating hormone from pituitary. The release of thyroid stimulating hormone, TSH, is influenced by release of thyrotropin releasing hormone, TRH, from hypothalamus. The secretion of both TSH and TRH is regulated by negative feedback mechanism from thyroid hormones, especially T3, in the circulation. When T3 and T4 are elevated, then TSH will decrease and the stimulation will decrease. Thyroid gland is composed of follicles, which are formed by cuboidal cells. And inside this follicle, there is colloid containing thyroid hormones. when there is decreased iodide in the diet, as in endemic goiter, or when there is an increased physiological demand, like in pregnancy and puberty, there will be an increased TSH stimulation through a negative feedback mechanism, which might stimulate follicular cells to work harder to produce more thyroid hormone from this low amount of iodide. The cuboidal follicular cells will become hypertrophied and become columnar in order to produce more hormones at this stage. The gland is called diffuse hyperplastic goiter. This is a reversible process if the cause, which is the decreased iodide in the diet or the decreased demand, will cease. Later, as a result of fluctuating stimulation, some of the active follicles become more vascular and hyperplastic until hemorrhage occurs, causing central necrosis, leaving only a surrounding rim of active follicles. Necrotic globules coalesce together to form a nodule filled with either iodine-free colloid or a mass of new but inactive follicles. Continued repetition of this process results in a nodular goiter. Most nodules are inactive, and active follicles are present only in the internodular tissue. This is an irreversible process. For that reason, once you see a multinodular goiter, then this process is irreversible and you cannot treat it by giving the patient thyroid. Investigations that should be used in thyroid diseases. First of all, you have to perform thyroid function test for every patient with goiter, because sometimes even when clinically the patient is euthyroid, but there is subclinical hyperthyroidism, and this could be detected only by performing thyroid function test. Ultrasound of the neck to define the nature of goiter, whether it is diffuse, multinodular, or solitary nodule. Radioisotope scan, which is either by iodine or technetium, again is useful in certain cases which will be discussed later. Fine needle aspiration cytology should be performed for any patients with multinodular goiter with a prominent nodule or special features in this nodule or in solitary thyroid nodule. Assay of thyroid antibodies against thyroid peroxidase, PTO, and against thyroglobulin. Also, assay of thyroid stimulating antibodies should be done. Ultrasound of thyroid gland. This can differentiate between diffuse goiter, multinodular goiter, or solitary thyroid nodule. It also can describe the nature of the nodules, whether they are cystic, solid, or both. It can give a count on the size of the gland and size of nodules. It can differentiate benign from malignant nodules to a certain extent using the TIRAD system, which is Thyroid Imaging Reporting and Data System. It will give an idea about the vascularity of the gland and the invasion of thyroid cancer to nearby structures. It also will show the cervical lymph nodes enlargement, whether they are benign or malignant. Thyroid scan using iodine or technetium is used in many cases. On scanning, the swellings are categorized as hot, overactive, warm, active, or cold, underactive. It's not useful for distinguishing benign from malignant lesions because majority of cold nodules are benign and some warm nodules are malignant, 5%. It is indicated in toxic features to differentiate between toxic adenoma, where the rest of the gland is suppressed, from toxic multinodular goiter, which is a secondary thyrotoxicosis. It is also indicated to differentiate between thyroiditis, early stage of thyroiditis like Hashimoto's thyroiditis, from toxic goiter, as to say Graves' disease, because during scanning you can see that in thyroiditis the gland will not take iodine or technetium, and it will remain black on scan. Types of goiter. First, diffuse hyperplastic goiter or simple goiter. It's due to stimulation of thyroid gland by TSH in response to low levels of thyroid hormones. The most important cause in endemic goiter is dietary deficiency of iodine. The other cause is increased physiological demands, especially during puberty, pregnancy, or lactation. Defective hormone synthesis is responsible for many cases of sporadic goiters. Enzyme deficiencies may be responsible for many sporadic goiters also. Certain types of vegetables like cabbage or kale, which contain thiocyanate, are considered goitrogens and might lead to sporadic goiters. Drugs like PAS and antithyroid drugs and iodine in large quantities can be goitrogenic. If TSH stimulation ceases, the diffuse hyperplastic goiter may regress to normal. Colloid goiter is a late stage of diffuse hyperplasia, when TSH stimulation has fallen off and when many follicles are inactive and full of colloid. If a fluctuation of level of iodine continues, then multinodular goiter is the result. Multinodular goiter is the end result of changes that occur due to fluctuating stimulation by TSH, where active lobules become more vascular and hyperplastic until hemorrhage occurs, causing central necrosis and leaving only a surrounding rim of active follicles. Then, necrotic lobules coalesce to form nodules filled either with iodine, free colloid, or a mass of new but inactive follicles. Most nodules are inactive and active follicles are present in the internodular tissue. This is an irreversible condition and cannot be reversed by thyroxine or iodine. Complications of multinodular goiter. Multinodular goiter might get very big in size to cause tracheal obstruction due to gross lateral displacement or compression of trachea in a lateral or anterior-posterior plane by retrosternal extension of the gland. Secondary thyrotoxicosis, transient episodes of mild hyperthyroidism are common, occurring in up to 30% of patients. Carcinoma or rapidly growing nodules in long-standing goiters are suspicious for malignancy.